Okay, well, I am really excited to introduce the 2022 Orthopedic Oncology Visiting Professor, Dr. Michelle Ghert. Dr. Ghert grew up in Toronto and then she came to the States for college. She studied at Stanford University and competed on the synchronized swimming team while there. She's still a lifelong swimmer and is raising two swimmers of her own. She then went to Vanderbilt for medical school and did her residency at Duke, where she worked with Dr. Vale. Following residency, she went back to Toronto and she completed a fellowship in molecular biology and orthopedic oncology at the University of Toronto. She then joined faculty at McMaster University in Toronto, and she's now a full professor there. I was looking up everything online and it said associate professor. And I was thinking, I don't think that's right. She's pretty amazing. So she is in fact full professor at McMaster University. She's the research director for the Center on Evidence-Based Orthopedics. And she is she's really, I would say, the epitome of a clinician scientist. So she has over 175 publications. She has basic science research, she has clinical research, and most recently, she spearheaded and completed an international multi-center prospective randomized clinical trial within the field of orthopedic surgery, which is nearly impossible to do. And we were lucky enough to be one of the 48 study centers and participated in the Parity trial. And I have to say, Dr. Ghert's leadership was not only instrumental in getting the project off the ground and to completion, but really inspirational. At every musculoskeletal tumor society meeting, she was sure to have an investigators dinner. And this was a chance for us to meet with other investigators, get updates on the Parity study, and really network. And it gave us, those of us at these centers where you've got a million things to do and you think, oh, should I enroll this patient? Then you think, yeah, I should enroll this patient because I'm part of something that's really big and it's going to change clinical practice. And it really has. And it's now given us information on the true rate of endoprosthetic infections, which if you look in the literature of all the retrospective studies out there, you'll see a range of 1% of endoprosthetic infections, all the way to 45%. And now we actually have some real numbers as well as data on how to treat these prophylactically around the time of surgery. And it's all thanks to Dr. Ghert. And we'll hear more about this now. I do want to say that she's a great leader, mentor, sponsor, and she is going to be taking over as the president of the Musculoskeletal Tumor Society next year, which we're really excited to see the direction that you take our society. And we can't thank you enough for coming, and we really look forward to learning more about the Parity study. So welcome, Dr. Ghert.
Wow, thank you. I really hope that the Parity study is it's not the end, it's the beginning. So I feel like after I'm presenting this several times, I feel like, well, it's done and now we're gonna, finish and that's it. I really hope that this can just be the beginning in orthopedic oncology and we're working towards that. So I really appreciate that. Thank you. What did I do wrong there? My computer's still on, so that's good. What about that? I can see the in person. Yay. Okay. Okay, with that being said, we'll get started. So as Rosie said, we have a high risk for amputation and endoprosthetic reconstruction in orthopedic oncology. And why is it high? Well, it's pretty straightforward. We do big surgeries, long surgeries. We take away a lot of soft tissue. Our patients are sick. A lot of them are immunocompromised. They've had chemotherapy. They're going to get chemotherapy. So it's really high. So how do you prevent an infection? There's so many different approaches. There's evidence for some, there's no evidence for others. But the American Academy of Orthopedic Surgeons and other societies recommend, at least for total joint arthroplasty, continuing intravenous antibiotics after surgery for 24 to 36 hours, or at least stopping them by then. There is evidence that any perioperative intravenous antibiotics will reduce surgical site infections. That's fairly well established. So you want to give something around the time of surgery. The question is, how long after do you do that? So we surveyed our community, orthopedic oncology community in North America, and asked, what do you do? What's your practices? What are your biases? Do you have equipoise? And you can see that we were all over the place. About a third of surgeons will prescribe what you would do for an arthroplasty case, which is what I would normally have done. And then some surgeons go much longer, and actually some people even go weeks, even with oral. So there was no consideration. Well, maybe I'm giving antibiotics too much, but because the more you give, the better. Because infections are so bad, you'll do anything to prevent them, and so just throw patients everything that you've got. So that was sort of the takeaway from that survey. So we designed a trial to determine if going longer, so 5 days, does reduce infection rates compared to 1 day. And we did not go past 5 days because we had a steering committee, and then the infectious disease experts on the steering committee said that you can't go past 5 days. It's not ethical. So, which was interesting because a lot of our colleagues are actually going past 5 days with intravenous antibiotics. So those were the clinical arms, and this is the research question, the overarching aim. So what patients did we have? So we had obviously primary bone tumors. That makes sense because that's where we're resecting them and using endoprosthetic reconstructions. But we also resect soft tissue sarcoma. Sometimes they invade bone. It's not common, but it does happen. And then you're putting in an endoprosthetic reconstruction. Um, and interestingly, this is just part because I do want to sort of inject this talk with experience along the way. Um, any trial, there's very few trials that don't struggle with enrollment for many different reasons. The Parity enrollment was okay, but it wasn't great. It could have been better. And some of our investigators said, well, I just did a renal cell met excision of distal femur and I put an endoprosthesis. Why can't I include that patient? So I thought, I don't know, why not? Because it's not the same population. Exactly. So we had a steering committee meeting, and I'll remember this as very, very clear. Dr. Gordon Ghert, who is my senior mentor, meaning that my mentor is Mo Bandari, and he was mentored by Gord Ghert. I guess you would say I'm a grandchild of Gord Ghert, even though he's not much older than me. So he coined the term evidence-based medicine in 1990, and he's the clearest thinker I've ever met in my life. He's an absolute genius in the way that he can see things so clearly. And he said, well, does the question apply to that population as much as it does to the other population? I said, yeah, it's the same issue. You got a patient, you want to prevent infection, you're doing the same surgery. They're probably going to live a year because it's a renal cell or it's a metastatic bone disease. So we started including those patients. And it wasn't a huge part of the study, but it did improve enrollment quite a bit. So that's another like tidbit as you go along doing this sort of study, because I had no experience starting. So it was a 10-year experience learning on the go. So the study design is fairly simple. It's a randomized trial. It's international, multi-center, parallel arm design. That just means there's two arms. That's it, long versus short. And we used a randomized.net system. That means that you can seal allocation. That means I can't pick what the patient's going to get randomized to. If you have envelopes with the actual allocation inside and you just pick an envelope, you can still look at it in the light and pick what you want. So this is sort of the gold standard. And these are the two regimens. So it all sounds very simple, but each center had to work out a plan because the patients were going to be randomized to one of the different regimens, and it had to be blinded, so that someone had to randomize a patient that was unblinded but couldn't be involved in the care of the patient, had to mix the drug and blind the drug. So we had to get pharmacy involved at every site. But basically, it was open label for 24 hours. So 3 doses of cefazolin or cefuroxime, depending on the center. And that was open label. Some people blinded all the doses, but it was open label. And then for the next 4 days, you get a blinded dose of either cefazolin or just saline, so that everybody got something, but they couldn't see what it was. And this is how we blinded the drug, at least at our site, though it was different at various sites. And everybody was blinded to treatment allocation. So the patients, the surgeons, the nurses, the data analysts, even the outcomes assessors were blinded. The only person that wasn't blinded was the the pharmacists who had randomized the patient, so they couldn't be blinded. So why is blinding important? We talked about this earlier. It's important because it minimizes bias in assessing outcomes, in directing treatment. If you did a huge case, it took 10 hours and they get randomized to 24 hours, you're going to be really jumpy if there's a little bit of drainage. You're going to take the patient back, or you're going to give them some antibiotics because you're worried. So that's just an example of why blinding is really important. It's a critical step in reducing bias. And as you go through the study and you live it, you really do see that, because I was curious and, I was wondering, what's this patient getting? And I was completely blinded to everything until the very, very end of this study, not just my patients, but everybody's. So the outcome was surgical site infection. When you're designing a trial, you have to be very clear what the primary outcome is. It has to be important to you, but more importantly, it has to be important to patients. It has to be easy to define so that you can clearly understand, everybody who's assessing the outcome can understand what exactly the outcome is. So we use surgical site infection because that's what we were trying to prevent, and we use the CDC definition. So as long as you have an established definition, you can't really be faulted for using an outcome that is clear and established, as well as important to patients. So this is what I wanted to talk about, because we did talk about outcomes assessment. So we have an adjudication committee, and this is an aspect of trials that you don't think about much. And I certainly had no idea about it before I started. And thank God I've got these people at McMaster that taught me and mentored me and directed me through this. So an adjudication committee are experts in the field that are willing to devote a lot of their time to adjudicating outcomes, which means assessing an outcome. Did an outcome occur or not? And I was involved, but we were all blinded. So every case that was adjudicated, I had no idea what center they're from, who the surgeons were, what their allocation was. So what happens is this global adjudicator platform, we had a coordinator who anytime an event occurred at a site, so it was either an infection, a reoperation, a death, or antibiotic related complication, or oncologic event, any of those were recorded, all the information was sent blinded, so completely redacted, to the coordinator, who uploaded it onto the system. And we had batches of review. So I would review maybe 15 cases at a time. It would take about 2 or 3 hours. You read all the notes, all the case report forms, any images that are there, and say, was this an infection or was it not an infection? Was this a death due to a metastatic disease or something else? And so it was a tremendous amount of work. And, as if, 15 takes 2 to 3 hours, and then we had to have a consensus meeting every 2 months or 3 months over the course of the study. And there were at least half of the patients out of 600 had at least one event, and some had many more. So it was very labor intensive. It was a tremendous amount of work. The people that volunteered their time, they're just heroes. I was really glad at the end of the study that we had done this, because of the results. And I'm standing up, saying, this is the results. If we had not done this step, I'd say, well, I'm not so sure, because an infection is hard to determine. You can have a wound healing problem and then get an infection because the wound's open, or you can get an infection that opens the wound. So it's hard to figure out which is which. And and if you have experts in the field and and they're blinded, they can work together to come to consensus. Are they always right? Probably not, but you get as close to the truth as possible. Bias is the opposite of truth. And so you minimize bias to get as close to the truth as possible. And data management is another thing that's very unique about these sort of studies. So we have a centralized database that is programmed at McMaster, and it's managed centrally there, but each site can log in and enter their data. And this is where you find quite a bit of difference between retrospective case series and prospective studies. There are 4 levels of data validation. That means that my research team every week or every 2 weeks goes through all the data that is submitted by all the sites. If they haven't submitted data, they get an email. If the data doesn't make sense or is missing data points, they get an email. So it's just this constant curating the data to make sure that when you're done the study, that you actually have the prospective data. And you'd think that it would all be entered right away and be very easy. It's actually not. So people just forget a data point or they put the wrong date in. So it's in every validation step they do the exact same thing. So when we got to the third validation step after we'd finished enrollment, I became somewhat unpopular with my colleagues because we were just torturing them with, we need this data, we need that. It was, and then when we got to the fourth, I definitely lost some friends. But again, at the end, I felt like, well, this is the best data you can possibly get. You can't get perfect, but we've done everything possible to make sure that if we have results of a study that we can stand by them. So this was a multi-center international study. So the sample size calculation to determine an actually clinically important difference in infection rates was 600 patients. And so that would take me 60 years of practice to enroll if I got 10 a year, which I wouldn't always do. So we have to work together. In orthopedic oncology, we treat very rare diseases. And so if we don't work together, we can't do these kind of studies. It would just take too long and more than our own actual careers, like 2 or 3 careers straight. So this required a lot of collaboration. And the question is, how did we do that? How do we get 48 sites or 55 to sign up in 12 countries? It just started with a couple, and then once that got rolling, our colleagues said, "Oh, that's happening. I want to be part of it." And so it just built on itself. People wanted to answer this question. This is important in our field, and also I was tired, and everybody was, of even 20 years ago when I was a fellow and I went to meetings, every single talk ends with, "But we need to do randomized trials to answer this question." So there would all be retrospective case series and every single talk. So after a couple of years, I'm like, why? Okay, why don't we do trials? So I think everybody felt the same way. And it was just a collaboration that has just been, I still don't know how exactly it happened. People ask me, other than it started somewhere and it built. And those first few centers that joined me at the beginning, they're the ones that should receive the credit because they took the leap of faith. So this is the enrollment, and so the bars are the enrollment per month, and then gold line is how many sites were open. And so we had a pilot and a few dropped out, and then we built, and then sort of leveled off about a year or two before the end of the trial. And you can see, like, some months were good, some months are bad, and my mood that month completely correlated with the number. So I was, really happy in January 18 because there was a lot of enrollment. I can't control enrollment. I can't do anything about it other than to contact my colleagues on a regular basis and say what's going on. Just like Rosie said, people get busy with their lives, and they're happy they're part of a trial and they enrolled a patient 2 months ago or 3 months ago and they're involved and it's great, but they have to screen every eligible patient. They've got to stay on it. And I know it's not easy. And if we don't stay in touch and ask people to remember that you're in the study and we've got funding for a certain period of time, and there are a certain number of patients that have already given themselves to the study, and if we don't finish, it's all a waste. So, and I'm really happy to hear that Jenner's help, because it was more just, for fun, but at the same time, I'm glad to know that keeps people engaged. So there's lots of different techniques to keep people engaged. So we finished enrollment October in 2019. That was a very big day. We did over enroll a few patients just because you end up having ineligible patients that have to be excluded. And I'll explain that in a minute. But okay, so here's the results. Okay, so we had 604 patient randomized. That's it. 611 were randomized, but 7 were adjudicated by the adjudication committee, blinded after the end of the study, that they were actually not eligible. So you can't cherry pick and see which patients you want to take out, but these are people that actually weren't eligible at the time of randomization, meaning they didn't have surgery, or so one patient was randomized the night before surgery or 2 days before and then died and then didn't have surgery. So that patient wasn't eligible, or they didn't get an implant because there was an intraoperative complication, or they had an amputation, there was an intraoperative complication. So we got down to 604, and they're about half into each regimen. The reason why there isn't exactly 300 is because the randomization was blocked per site. What that means is each site, if I enrolled 20, then the randomization system was programmed so I'd have 10 in each group. I wouldn't know which, but so each site enrolled equal. But if you have 10 sites that are enrolling 3 patients, then you're gonna have 2, 1, 2, 1, 2, 1. So it's not gonna be exactly equal. And so that's why it's not 300, 300. And actually, after I saw them, like, oh no, that's not good. But then there are data analysts said that's totally fine. And the journal that we submitted to didn't have an issue with it. So I guess it's okay. Okay, so you always want to look at the baseline. Why do you look at this? So you want to make sure the groups are equal, the same, and all possible confounding variables. You randomize to balance known and unknown confounders. We have some confounders that we know, but there's some that we don't know. And randomization will balance those. And before this, I thought randomization was a scientific method. It's actually magic because I couldn't believe the numbers I was seeing. The operative time was the same to the minute. And it was just so precise. It was incredible. I thought that's an amazing process. And we don't think about it much, but it actually is probably the most critical process in doing any prospective research. So crossovers are something you try to avoid because you don't want patients going to the other arm, because then you got to figure out how you're going to analyze them. They were fairly uncommon, so that we were happy about that. Protocol deviations were pretty common though. These we considered most of them minor. And so we had 15 doses. And how many people actually got 15 doses? Not that many people left the hospital before they finished the trial, which is fine. Nurses on the weekend would miss a dose. That's actually, I didn't realize how common it is for nurses not to give certain doses until this trial, because we had to, we go the MAR every day and check. Unbelievable. It was unbelievable. I mean, and you think about what happens when I'm not paying attention. I'm not saying it's not the nurses are bad, whatever. It's just life. So anyways, this is life. And I thought it was interesting, but they were the same between both groups. So again, if you're randomizing, it's okay. So this is the surgical site infection rate. It's high, 16%. And this includes all like superficial, which were very few, and deep and organ sprays. This is more than what's been reported. We did a systematic review and it was about 10 to 12%. But this is higher for various reasons. One, it's prospectively collected. Two, we had a fairly broad definition, any surgical site infection. So, but this is probably closer to the truth. It was more than we expected. So here's the meat of it. The infection rate was 16.7% in the short regimen and 15.0 in the 5-day. So a hazard ratio of 1 is same risk. So it was 0.93, and the confidence intervals were actually pretty wide, meaning the truth can fall into anywhere near there. So it's not a very precise outcome. You'd want to have 0.99 to 0.101 to 1.01. That would be perfect, but you need 1 million patients literally to do that. So, but this, if you just look at this and you say, okay, I want to reduce the risk of infection in this patient. Well, I don't think looking at this, that antibiotic duration is going to be the technique that's going to do that. That's what I get out of that. It doesn't mean that there isn't a difference. There could be a very, very, very small difference, but it's not enough to consider all the other aspects related to intravenous antibiotics. So we do sensitivity analyses, and that's just, there's a secondary analyses to make sure that the data is robust to different factors. So patient could die or have an amputation, but then if they do that, they can't get an infection. It's called a competing risk. So we did a sensitivity analysis for that, and it was the same outcome. We adjusted for clinical site because each site has different techniques of doing everything. So that was similar, and we do it per protocol analysis. And what that means is if you do an analysis intention to treat, that means if you're randomized to A, you get analyzed in A. And if you're randomized to B, you get analyzed in B. And why do you do that? Because it sounds strange, because if you cross over, you should be analyzed in per protocol. But the actual gold standard is intention to treat. And the reason why is the reason why you cross over is not random. People cross over for various reasons, and that's not random. So you're actually introducing bias if you don't analyze intention to treat. But it's a good idea to do a per protocol analysis just to make sure that there isn't anything that you're missing. We did subgroup analyses. These are all, we publish our statistical analysis plan ahead of time. That way we can't massage the data and find a finding that we want to find. But you have to actually be completely transparent. This is how we're going to analyze the data, period. And then later you look at the data. So we thought about looking at subgroup analyses. Does the antibiotic duration differ in men and women, or tibia, femur? And it didn't really have, or chemotherapy didn't have any difference. So our secondary, we have a bunch of secondary outcomes. I'll go through them fairly quickly, but this one is the one that is important. Any antibiotic related complication that was reported to the adjudication committee was reported as an adverse event, meaning they had to have intervention, hospitalization, or some sort of medical intervention. So these are serious events. They're not someone got a bit of a rash and didn't do anything about it. So there were 7%, and they were more common in the long group by order of 3, with the confidence intervals that again are wide, but are fairly well clear of 1. So this is interesting. So when we were ready to look at the data, it was still blinded. It was A and B. And so we had a meeting with the writing committee, and we looked at the data, and it was A, B, and we could see, okay, there's no difference in infection. I wasn't surprised, and I didn't know which group was what. And then Dr. Ghert, he looked at this outcome blinded, and he said, "Oh, now I know what group is what." And I, like, first, thanks for unblinding me. He's not supposed to do that. And I said, "No, that could be spurious. That's probably nothing." He's like, "No. He's an internal medicine specialist." He's like, "No, that's real." And so he was right. And he could clearly see that if you give 5 days of intravenous antibiotics, the risk for an antibiotic-related complication is higher, significantly higher than if you just give the standard post-op 1 day. The most common was diarrhea, but C. diff diarrhea was the most common. Okay, so other outcomes. 1 in 4 of our patients go back to the OR. That's how bad it is. It's bad. We have very challenging practices. But that didn't differ between groups. And of course, the most common take back was an IND. We have oncologic events, 30%, and we also had 13% death. But those didn't differ between groups. You wouldn't expect the antibiotic to have an effect on those anyways. And most patients that did die died because of disease progression. So what are the strengths? We lost very few patients. So 13% died, but if you take that into consideration, we lost 5% of patients, which is pretty good. In trauma trials, they tend to lose quite a bit more because patients just get treated for their fracture and they leave. Our patients like to come back and see us. So still, even 5%, I don't know where those patients went. I actually lost one. I couldn't find him. It was crazy. But I honestly, I couldn't, we did everything. I don't know where he went. I still don't know where he is. But so it does happen. It's real life. We had broad eligibility criteria. So if you have a metastatic bone disease patient, you can apply this information. If you have osteosarcoma patient, same thing. And we had diverse healthcare systems. So we had a lot of American sites. So you have a certain type of healthcare system. Canada is different. India, South America, Europe, they're all different healthcare systems, so that you can apply the results of the trial to your site, most likely. Surgical site infection is important. We chose this, the doctors chose this as an outcome. I've learned from the more recent trial that I'm working on, it's actually more important to ask patients what's important to them, so that your outcome actually is important to them and not just you. It doesn't have to be mutually exclusive, but you need to get their perspective, because that's why you're doing the research. And so we had a lot of safeguards against bias. We concealed randomization, we blinded. The outcomes was blinded and objective, and also we interpreted the results. So after we saw A and B, and I tried to ignore what Ghert had said, we wrote a document saying, if A is this is our interpretation. If B is this, if A is this, this is our interpretation for each of the outcomes. And so that was already written and done and sealed and signed. And then we found out what A and B was. So we couldn't start reinterpreting things because we wanted it to look a certain way, which is something I hadn't thought of course, but I just do what people tell me to do. And most important that we got a bunch of people to work together. So there are always limitations. There's no perfect study. When we are determining a surgical site infection, it's really challenging. The adjudication committee, we had some challenges because infections are not always cut and dry, particularly with an implant. So we did the best we could by adjudicating centrally. That's all you can do. And so some sites didn't enroll many patients for whatever reason. And so that didn't balance out exactly to 600. So, but it's something that would have been better if it was perfect, but it still was acceptable. And so we can get late infections in our implants, probably the same in joints, but those are probably not related to the surgery because the CDC actually says it has to be within 1 year. But we've had a lot of feedback saying, yeah, I'd like to know what late infections are. And I would have loved to follow these patients longer, but it would have been a very, very expensive. So, and we didn't ask for funding for that, but that would have been something to think about. And we had wide confidence intervals, meaning, the truth can lie anywhere between a certain two numbers, even though it sort of balances, it peaks at 1. But if the difference really is 1.7%, then is that really that important to find that is that clinically significant? To find that as statistically significant, you'd probably have to enroll thousands and thousands of patients. And are we really willing to go ahead and do that just to know the difference? And I think that really the point is that we're providing information for physicians when they're making decisions. So we're not telling surgeons what to do, and we're not saying that the data is exact. What we're saying is this is the information that you have when you're making a decision. So we didn't demonstrate a benefit of 5 days. It could still be there based on the confidence intervals, and it could actually be worse based on the confidence intervals, but we don't know for sure. But there's no benefit that we can see. We were not able to prove a benefit, but there was definitely a higher risk for antibiotic-related complications. And C. diff is, Yi in Oregon. So she's on the writing committee, and she said we were talking about C. diff, and she said, I recently had a patient with C. diff. I'd rather put a gun to my head than treat that again. It's actually a nightmare to treat. So I usually give that to the internist and medical oncologist, but I guess she got stuck taking care of it, and it's really bad. So you have to think about that. You don't want to cause harm. So when you're making a decision, you have to understand the uncertainty, the benefits of antibiotics, of long-term antibiotics, but you're pretty sure that there's an increased risk of harm. So I just want to acknowledge the sites. We had Canadian sites, and I'm happy to say we have 2 slides of American sites, and UCSF, is right there with our colleagues. So I'm grateful for your collaboration. International sites, and then the next few slides are just the dinners that Rosie was talking about. It really was a unique experience to bring together our orthopedic oncologists are all cut from the same stone. We all understand each other, and it's really wonderful to get together and commiserate on our practices and celebrate our families. And so anyways, this was published in January. This is just a screenshot. And this is what that paper actually looks like. So you can see that the author was really, really clear with the journal that authorship is not going to have my name in it. It's going to be the Parity investigators, because I didn't do this so that I would have my name on top of a paper. If I was doing it to put my name in a paper like this, no one would work with me, because that's not what people want to do. We want to collaborate and be a group. But if you click on the authors on PubMed, their journal was not happy with us. Yeah, it was about 350 people, because we included investigators as well as the pharmacist and the research personnel. So everybody, one of these people is indexed. So if you search for yourself on PubMed, this will come up. Okay, and yeah, we spent a lot of time writing grants. It's just part of what you have to do to run this study. You can never ever stop. You have to keep writing grants, and you just get better at it as you go. You have to have very thick skin, and it can be very, very challenging. But we just kept going, and we were able to get enough funding to finish. And that's it. Thank you. Questions? Yeah.
Yeah, thank you, Dr. Thank you, Dr. Ghert. So we do have time for questions, and I'll pass the microphone around. We'll start with Dr. Vale.
Thanks. Really outstanding. I just to put all that together, it's very, very, very impressive and well presented. Thank you. I wanted to start with a question on where you ended there with the funding.
Yeah.
How do you get a study funded when there's really no track record for prospective studies?
Right.
And then how did you coordinate the multiple funding groups? What role did they play in the total picture?
Yeah, that's a good question. So when you want to start a trial, you got to start with background work. So you have to do a systematic review, costs nothing. A survey of the field costs nothing. So you get those two done, and then you have some background information. And then you also maybe want to get some letters from some centers that want to participate. So if you've got all that, then you submit a proposal for a pilot study, meaning 10% of the enrollment. It's just to see if you can actually do the study. A pilot study means that I can enroll, I can follow the protocol. I don't lose patients, I don't lose data. The data quality is good. It's not a clinical question. You're not asking a clinical question, you're just answering feasibility. And so a lot of funding mechanisms are supportive of that. The CIHR is pretty good with that. They like to fund pilots because they're not throwing away a lot of money. They know if it doesn't work, they haven't given away too much money. So I would start with a pilot. And so the question is, how do you have a successful pilot? You have good background work. You show that it's important in the field. Obviously, you have to design it clearly. If there's someone who reviews it as a methodologist, they're going to have to really be happy with it. And then you need mentorship and backup. So, Mo was on my first few grants. Gord was on my grants. If they see those names, it's you're already one step up. It doesn't mean you're going to get funded. So I think having some shoulders to stand on when you're getting started is very, very important. You can't do it by yourself. So once you get the pilot and it's good and you're actually able to enroll, that is a little bit more of a slam dunk. So CIHR, so we got pilot funding from the Canadian Cancer Society. MSTS was pilot, and Physician Services Incorporated. And then we got, so all that was put together, and that was about 500,000 Canadian, 600,000. And then we applied to CIHR, which is our NIH, for the definitive funding, and that was about $1 million Canadian. So it's not very much for you guys, but it was enough to finish. So you start with small, and it's like it's like a stairway. You got to get one step at a time. I would not submit a grant and say, I want to do this big randomized trial. I don't know if it's important. I don't know if people want to participate. I don't know how to answer the question. Like you have to really build on what you want to do. And so does that answer it?
That's great. Thank you so much.
Thank you. Am I on? Thank you so
Yeah.
much. I was wondering if you could tell us a little bit about some of the ongoing secondary analyses, and if there are any that you're very excited about.
Yeah, oh my goodness, especially yours.
Right, yeah, and especially mine.
Oh my gosh, I have to, is it okay if I pull up something? Because
Please.
There's a lot. I can't remember all of them. All right, it'll be here. So can you explain what second with
Yeah.
that was great? Yeah.
Yeah, so once the Parity data was finalized and they published the paper, Dr. Ghert and the steering committee opened up people to ask secondary questions. And so all of us submitted our one-page proposal, and then we would hear back whether or not we could proceed with the analysis. And we were lucky enough to get an opportunity. And then they sent us this amazing data. It was so nice, the data sets. And then we were able to answer our questions. And so we asked whether or not there was a difference in 1-year progression-free survival between patients that had an infection and those that didn't, because we've been interested in whether or not an infection stimulates the immune system to then fight the tumor, kind of immunotherapy. So that's what we were asking. And we didn't find a difference in 1 year, except among people that had metastatic disease at baseline. They did much worse, and they had a much higher hazard ratio that was statistically significant for 1 year progression. but I was really interested in what other.
But other ones, yeah. So we contracted with JBJS for a supplement, which means you just pay the money. And they do have peer review, but they tend to only give you one round with JBJS, it can be 3 or 4. So it's nice. It's a little bit more pleasant to submit. So let's see. The first one, actually, we just looked at the data for that one. So that was, I think this is fascinating. The site investigators said this is an infection, and then they submit the information to the adjudication committee. We wanted to see how often that got reversed. So it actually, I think the agreement overall was fair. So not very good and not near perfect. So that was, I think that's more of a methodology paper, but that goes to show that if you do a trial and don't have adjudication committee, you're relying on individual investigators at each site to make the diagnosis, whereas having a blinded and completely objective look at it by consensus committee is actually going to give you a different outcome. So that I thought was interesting. So then there's surgical risk factors for reoperation and for infection. That is really challenging because we're not really powered for that, and you don't want to make too strong conclusions. And same with implant type, fixation versus cement. I think that's interesting, because we always say, you need to cement, you need to press fit. I think it's neither here nor there, but to see if there's actually a difference in outcome. Again, we're not powered for that. I just saw the paper for a thromboembolic events. That was interesting. Yeah, it was interesting because there's only 1.8% risk, but we didn't assess. We didn't look for. These were symptomatic thromboembolic events. I haven't seen the VAC. Yours is similar to the deep infection correlating with lower extremity. Yeah. But you looked at peds? Oh, no. Yeah. Right. So you're 8? 7. Oh, right. Sorry. So peds? Yeah, okay. Peds is, I can't remember. I'm sorry. I've had to edit all these. It's hard to remember. Opioid consumption was interesting. Aaron, he's a resident works with me. He probably did he just done so much. He's really, really quick and fast and done really well. He looked at this and he was really surprised because the number of patients that are taking chronic opioids at 1 year is very, very low in our population. He thought that was different because in some other orthopedic populations, if they're on opioids for a while, they're going to be on opioids at a year. But in our population, it was not. That wasn't the case. We looked at functional outcomes, adult versus peds, and that's been interesting. And of course, peds do better. This is I do this for Henderson classification of failure of implants. I think that's only used in orthopedic oncology, but it's Eric Henderson and a large group developed a classification system for failure of orthopedic oncology implants. And he is using the Parity data to sort of refine that. So that's exciting. I haven't seen the biopsy one yet. Haven't seen surgical length of time. This is a lot. This has been published. Minimally clinically important difference is something that it's not, you can find a statistically significant difference, but it really doesn't mean anything to the patient. So there's various ways to calculate what is a meaningful outcome to patients. And so that has never been done for the MSTS or TESS, or I think TESS, one of them has been done once in a different population, but in this population and really at all. So that's already been published. A minimally clinically important difference. So that helps in further studies. So if you do an intervention and the function improves, is it clinically important? Same thing. Who recovers quicker? I think I saw that. I didn't find anything remarkable there. I haven't seen the geographic variability. That will be important. I think some of these are still open. Factors affecting extension. Okay, yes, we can't do that one because we don't have enough information, but that was a question that came up. That's number 17. But we are going to look at 18, which I thought is interesting. Some sites said, well, if the soft tissue mass is posterior, your risk is higher for recurrence because there's more neurovascular structures there. So that's going to be interesting. Neoadjuvant chemo timing, does that affect infection rates? And that's been published in Annals of Surgical Oncology. Tourniquet use that we reviewed today is and published in BJJ. And we want to find out, did the Parity trial change practice? That you kind of have to give it more than a few months. Like it was published in January, so we'll probably do that next year. Oncologic events, we haven't done that. These are not assigned to authors yet. Risk for mortality. And I think I highlighted these because these are really interesting. The microbiology profile is going to be very interesting, based on geographic variation and weight-based antibiotic doses. So yeah, some centers didn't do weight-based, so that we do have the body weight. So we're going to see if that actually, if you really did need to go with 3 grams or 2 grams. The other one that we don't have here that is very important is protocol deviations. I think that if we can look at of all the people that all got 15 doses, they're still it's confounded, but to see if the protocol deviations actually made a difference. I don't think so, but we should definitely look at that. We did get a letter to the editor. This was really interesting. They said, you're using the wrong antibiotic. And I thought, what? Cefazolin, covers pretty much orthopedic bugs, staph epi. It has extended spectrum, so you can cover some gram negatives. It has, great absorption into the musculoskeletal system. Our arthroplasty colleagues had surveyed North American surgeons on what they use, and 95% use cefazolin or some sort of cephalosporin. So I thought that was really strange. And so we're able to pull together we have the microbiology data, but that's not released yet. But there were 45 different organisms that were cultured in the study. And of course, staph and strep were most common, but there was a whole bunch of others. So that's going to be interesting. So maybe, are they right? We didn't use the wrong antibiotic. I don't know. Right antibiotic. I don't know. I thought that, no one ever brought up the fact that we should be using another drug. Yeah. So, but there was very little MRSA, which was good. So this is things that we're looking at. And so, every few days I get another paper because we're supposed to be submitting to JBJS now, and a lot of them actually have been submitted. But I read them and edit them, and there's some interesting stuff. But again, it's all secondary, so it's not definitive. It's just exploratory. And the reviewers for JBJS have been absolutely vicious, just tearing it apart. I'm like, okay, fine. So, you just respond with what you can. Actually, one had so many pages of comments that we pulled it. Yeah. And then we sent it to another journal and it got accepted within like one revision. So anyways. So yeah, it's a lot of fun. And and January 6th, 2023, all the data will become publicly available. So you can do any research that you want on it. Yep.
So I believe looking at drains is part of one of the secondary analyses. We didn't do it, but
I haven't seen that one.
That's been the question because, these numbers that we decide, okay, at this output, we'll pull the drain really is what has led to our duration of antibiotic use, because the idea of having a plastic tube touching the metal and then coming outside the skin, I'm like, oh, we have to have a drain. And we understand our plastic surgery colleagues for soft tissue reconstructions oftentimes don't keep patients on antibiotics, right? They put in drains and antibiotics. But every time we send a patient home with a drain, it's who has a soft tissue, some kind of soft tissue removal. We have them on a prophylactic antibiotic. And then when they're in the hospital, they're on antibiotics. And it's a good point. It's like, okay, who's getting C. diff? But it's hard to reconcile that, right? It's scary to think about, do I just not have the drain? Because maybe the swelling won't be as bad as I think it will be. So that's always been, I feel like if I can get over the drain question in my head, it's easier to accept the antibiotic, like shortening the duration.
Right. It wasn't on this list, huh? Oh, okay. I haven't seen that paper. I don't know if somebody's working on it. If they're not, you're welcome to have the data. And
I'll go for it.
Yeah.
Because honestly, I think the patients don't love the drains.
Yeah,
Right.
yeah, yeah.
Nobody loves having a drain. Everyone's so thrilled to take it out.
Yeah.
And, but it, it's mostly to help us sleep at night that they're not developing some big hematoma around their like neurovascular.
Yeah, no, I know. I stopped using drains. I think, it was TXA that stopped me using drains because they just don't drain as much afterwards. They don't bleed as much. But I don't know. More recently, I started to get some pretty big seromas / hematomas. Maybe I should use a drain. I don't know. I am the same with you. I don't want plastic touching metal, then touching skin. That just doesn't make any sense.
Well, there's the next randomized study.
That
There you
actually is
go.
doable.
Do you have it in you? I mean,
I've got safety going now. Yeah. I don't, yeah,
choose the machine.
there
It's
has to
like
be.
inspiration.
Oh. Okay. No, anyways, you have to have clinical equipoise. So are surgeons willing not to put in a drain? That's the question. Or to put one in for me. So they'd have to do a survey and find out if people will be willing to do that. But that's a good thought. That would be manageable. And not, I'm never going to do a drug trial again. Because actually, of course, another thing you don't think about when you start, if you're giving intravenous drugs, we had to get Health Canada approval. FDA gave us a buy, which is good. And European, we had to get European approval. Each country had to have an approval, and then each center had to have approval because it was an intravenous drug. Even though cefazolin has been around longer than most of us. Yeah. So yeah, no more drug trials. No. So we know what's interesting is our center, they're doing a huge trial on PrEP in open fractures and closed fractures called PrEP-IT, and it's highly funded, and it's American funding. And they were so fast at enrolling. That's why I said that most trials are slow because they are doing a cluster crossover trial, which is you basically, each center says, okay, you're going to use chlorhexidine this month or next 3 months, and you're going to use betadine these 3 months, and then you're going to switch. It's called a cluster crossover. And when you do that, you don't have to get consent from patients because that's the standard of care at that center. So they don't get consent. They get consent after surgery and say, can we follow you? Period. That's it. So, I still think that's cheating. But I find that cheating. I like to talk to patients. You're going to take a risk here. Is that okay? But they enrolled very quickly, and they'll get the same answer as if they got consent or not. So maybe that's something to think about in the future. Cluster crossovers, but they enrolled faster. They actually finished early. So it's incredible. It's incredible if the way you design a trial will tell you how you get it done. I'm still not ready to do that, but I think it's an option. Yeah, I'm pretty sure. Yeah, I mean, a lot of the larger centers in the U.S. It's PCORI funded, so and that's NIH, and it's central at shock trauma. But I think McMaster's running it, sort of like a collaboration. So, yeah.
Yeah, Michelle, I just wanted to give a final thank you. First of all, for including our center in the study, giving us the opportunity, but the three of us sitting here were just kind of along for the ride. But one of the things that often goes unsaid, not by you, but you did put two names up there, Adriana and Veronica, who are clinical research coordinators. And I just absolutely love working with residents. But as I look back on my time here, working with staff and helping them along has been equally rewarding. And I think, as we as a department move to hire more CRCs and get involved in this type of work, just put in a plug because they're the people that really do the work. And, thankfully, Adriana started on this study. She's now finishing medical school. And Veronica, who took her place, is now got her master's and leaving next week to go to Roche. Another one of my practice coordinators is now, he's the director of the cancer center in the East Bay. So he's now the boss of me. But that is really gratifying. I think you'll agree as we go on. And so thank you not only for the opportunity for us and for our patients, but also for our staff, because it's a tremendous amount of work, as everyone can see.
I completely agree. We would all be lost without them, completely lost. So you're absolutely right. They're the backbone.
All right, it looks like we're right at 8:30. So Dr. Ghert, thank you so much again for coming. This was so impressive and really inspiring too.
Well, thank
So
you.
appreciate you making the trip.
Thank you. And I'm happy to be here. I've had a great time.